Hi everybody, and welcome to our module on aortic disease. Let's start by talking about aortic dissection. So recall that the walls of the aorta are made up of three layers. The innermost layer, the layer that touches the blood moving through the aorta, is called the intima. The middle layer is called the media, and the outer layer is called the adventitia. An aortic dissection occurs when there is a tear in the intima, and this allows blood to get in between the intima and media, and this is called dissecting the walls of the aorta. And you can see this in this cartoon on the screen here. We've got the intima, the media, and the adventitia. And if there's a dissection, blood leaks and gets in between the intima and the media, and that can begin to propagate and move down the aorta. And this is a condition called aortic dissection. We think about aortic dissection in terms of two types, type A and type B. Type A aortic dissections involve the ascending aorta and or the arch. If you look at this picture on the screen, if a dissection involves any of this portion where I'm circling with my pen here, we call that a type A dissection. And these are medical emergencies and they're always treated with urgent surgery. Type B dissections involve only the descending aorta, so that would be anything from here on down. And these are usually treated medically. The reason is that the mortality from surgery is so high that usually we treat them medically with blood pressure medicines and medicines to control symptoms, and then we let the dissection heal over time. So to understand the clinical features of aortic dissection, you need to understand that these dissections can propagate. So once blood enters the dissection plane, the aortic dissection can begin to spread. So let's look at this drawing on the screen here. And for example, let's imagine that we have a tear in the intima right here. Well, blood can enter the plane between the intima and media and spread down this way, and that will cause problems with the aortic valve and the heart. Or it can spread this way, and that will cause problems with blood flow to the head and neck. And it can even spread all the way down here and cause problems with blood flow to the lower extremities and the kidneys. So depending on where the dissection is and how far it propagates, that will determine the clinical features of an aortic dissection. So if it propagates towards the aortic root, looking at this picture here, imagine that the dissection propagates this way down towards the aortic valve, the aortic root, and the heart. That can cause a couple of clinical problems. First of all, it can cause aortic regurgitation, so a person with a dissection can develop heart failure from severe aortic regurgitation. Fluid can also enter the pericardial space around the heart and cause tamponade. And most people who die of aortic dissections die because they develop tamponade. They have an aortic dissection, fluid rapidly accumulates around the heart, the left ventricle can't fill, and that leads to cardiogenic shock and death. You can also develop myocardial ischemia. If you look at this drawing on the screen here, the right coronary artery comes off right about here at the base of the aorta. So if the dissection disrupts blood flow through the RCA, that can lead to myocardial ischemia. Going in the other direction, a dissection that propagates and involves the aortic arch can cause stroke by disrupting blood flow to the carotid arteries. The aorta can enlarge and compress the sympathetic nerve fibers that innervate the face, and this can cause Horner syndrome. And it can also disrupt the recurrent laryngeal nerve, which travels near the aorta, and this can lead to vocal cord paralysis and hoarseness. Aortic dissections that involve the distal aorta, those type B ones we talked about before, can cause problems with blood flow to the limbs. It can cause limb ischemia if iliac blood flow is disrupted. The mesenteric vessels can be disrupted, causing mesenteric ischemia, and the kidneys can also be affected if the renal arteries have decreased blood flow because of the dissection. So now that we've gone through all that, let's talk about the symptoms and clinical findings of aortic dissection. The classic description of pain from an aortic dissection is tearing chest pain that radiates to the back. In real life, the symptoms of dissection can be vague and often dissections are missed, but in terms of board questions, if they're going to describe a classic case, it's going to be described as tearing chest pain radiating to the back. Another classic finding in many dissections is asymmetric blood pressure, so a difference in blood pressure of more than 20 millimeters of systolic pressure between the right and left. And this happens because if the dissection disrupts blood flow to one arm but not the other, then the blood pressures are going to be different in the two arms. A widened mediastinum on chest x-ray is a classic finding in aortic dissection. As blood enters the space between the intima and media, the aorta enlarges, and on a chest x-ray, the aorta is what occupies much of the mediastinum, so you can see here in this picture on the screen, this is a very wide mediastinum compared to what you would normally find, a classic finding in aortic dissection. Let's talk about some of the risk factors for aortic dissection. The number one risk factor is hypertension. Patients who have hypertension can develop an aneurysm, which is an enlargement of the thoracic aorta, and that can eventually lead to dissection. Patients who have atherosclerosis in their aorta are at risk for aortic dissection, and then any patient who has an enlarged aorta in the thorax, which is a thoracic aneurysm, is at risk for dissection. If you have a collagen vascular disorder like Marfan syndrome or Ehlers-Danlos syndrome, these people are at higher risk of aortic dissection. And then there are some other special conditions associated with aortic dissection. Anyone with a bicuspid aortic valve will also have an abnormal ascending aorta. That's because when the aortic valve does not have the normal three cusps, this alters the tension on the aorta and leads to potential aortic enlargement and dissection. Turner syndrome, which is a congenital disorder of sex chromosomes, often leads to bicuspid aortic valve or to coarctation of the aorta, and both of these conditions predispose to aortic dissection. And then this is very rare in the modern era, but years ago, before the antibiotic era, there were many patients who had tertiary syphilis, and tertiary syphilis often leads to inflammation of the aorta, a condition called aortitis. So many of these patients with tertiary syphilis would develop aortic dissection. This is very rare in the modern era. The diagnosis of aortic dissection is often suggested by a classic history, exam findings like blood pressure differential between arms, and a chest x-ray with a widened mediastinum, but the definitive diagnosis is almost always these days made by CT scan. This is a CT scan on the screen here of a patient with aortic dissection. Contrast has been injected to make the aorta here turn white, and what you can see is this dark piece of tissue here. That is a dissection flap, and the blood in the space the arrow is pointing to is blood in the dissection plane between the intima and the media. So this is a fairly classic picture of an aortic dissection. You should be able to recognize it on your board exams. In patients who can't have a CT scan, often these are patients with renal failure who can't tolerate the dye. There are alternative ways to make the diagnosis, and these include MRI or transesophageal echocardiogram. As I mentioned before, type A dissections are treated with emergent surgery. These are dissections that involve the aortic root, the ascending aorta, or the aortic arch. Type B dissections, which involve the descending aorta, are treated with medical therapy, and the goal of medical therapy is to lower the blood pressure. When patients have a type B dissection, they have a dissection involving the descending aorta, and higher blood pressure causes that dissection to propagate. So what you want to do is get the blood pressure down as low as possible and give time for the tear in the intima to heal. So this is usually done in the hospital. Drugs that are rapid acting are used, drugs like IV esmolol or labetalol or sometimes nitroprusside. And once again, the goal is to get the blood pressure as low as possible so that the dissection can heal. Surgery is generally not done for type B dissections, and that's because the mortality is so high. Moving on, let's talk about aortic aneurysms. An aortic aneurysm is a dilation or bulge of the aorta such that the diameter becomes more than 1.5 times normal. Aortic aneurysms always involve all three layers, so the intima, media, and adventitia are all part of the bulging section of the aorta. And clinically, we subdivide aortic aneurysms into those that occur in the thorax and those that occur in the abdomen. Thoracic aortic aneurysms involve usually the root, the ascending aorta, or sometimes the arch. Abdominal aortic aneurysms usually occur down in this area near the renal arteries. We'll talk about thoracic aortic aneurysms first, and you can basically think of a thoracic aortic aneurysm as a precursor of dissection. That's the major risk here, is that if left untreated, these aneurysms will lead to dissection. They almost always occur in the proximal ascending aorta in this section right here. It's very rare to have them beyond this section here. And just like the major risk factor for dissection is hypertension, the major risk factor for aortic aneurysms is also hypertension. In addition to this, some other typical cardiovascular risk factors also are associated with aortic aneurysms, things like hyperlipidemia and smoking. And as I told you before, dissection often occurs in patients who have some type of aortic disorder. The same is true of aortic aneurysms. So just like patients with Marfan syndrome are at risk for dissection, they're also at risk for aneurysms. Same is true of patients with Turner syndrome, bicuspid aortic valves, or tertiary syphilis. And when patients have one of these conditions, like for example Turner syndrome or Marfan syndrome, they are often monitored with regular transthoracic echocardiograms. These studies can see the proximal aorta, and what you're doing is you're screening the patient to try and detect an aneurysm before it gets so large that the patient has a dissection. Most aortic aneurysms are asymptomatic, but if the aneurysm involves the root and it's big enough, it can pull the leaflets of the aortic valve apart, and that can lead to aortic regurgitation. As I mentioned on the last slide, these are usually diagnosed by echocardiography, sometimes also by CT scan or MRI. If you look at this image on the screen, this is the root of the aorta here that I'm drawing with my pen, and so you can measure this root by echocardiography, and if it's above normal, then you know that that patient has an aneurysm. And there are criteria for when aneurysms are so large that they should be operated on to prevent dissection. For most patients, we refer them for surgery if the aneurysm is greater than 5.5 centimeters. A normal diameter of an aortic root is less than about 3.5 or 4 centimeters, so 5.5 is significantly enlarged. Abdominal aortic aneurysms, as I said before, are aneurysms that occur in the abdominal aorta near the level of the kidneys, and these are much more common than thoracic aneurysms. And most abdominal aortic aneurysms are associated with atherosclerosis. You can basically think of them as a complication of vascular disease. When patients get a significant amount of atherosclerotic plaque in their abdominal aorta, that often leads to the walls beginning to bulge out because the plaque weakens the walls, and that leads to an aneurysm. And the most common site is just below the kidneys in the infrarenal aorta, and the reason this is the most common site is because that's the area most commonly affected by atherosclerosis. Super high yield to know that smoking is the strongest factor associated with abdominal aortic aneurysms. Every patient I've ever met who has a AAA is a smoker, and most of those patients also have other vascular diseases like carotid artery disease or lower extremity peripheral vascular disease. This problem is much more common in men, and it's much more common as you get older. It's very rare before the age of 55, but as many as 5% of men over 65 have an abdominal aortic aneurysm. And then in addition to smoking and gender and age, these aneurysms are also associated with other vascular risk factors like hypertension and hyperlipidemia. Most abdominal aortic aneurysms are asymptomatic, but sometimes they can be detected on physical exam. Because the abdomen is soft, if you press down in patients with large abdominal aortic aneurysms, you can sometimes feel a pulsatile mass. Classically, it's identified between the xiphoid and the umbilicus. The natural history of these aneurysms is that they will enlarge over time and eventually rupture. So the goal of managing patients with aneurysms is to decide when surgery is indicated. They're followed with ultrasound usually, or sometimes CT scan. This is an ultrasound image of an abdominal aortic aneurysm on the screen here. You can see there's some plaque along the walls of the aorta, and you can also see that it's very large. And usually we recommend that patients have surgery when the aneurysm gets to be over 5 centimeters in size. A normal diameter for the aorta is about 3 centimeters, so 5 is significantly enlarged. I'll finish with this slide on screening for abdominal aortic aneurysms. This is super high yield for board exams. It comes up on the STEP exams, the medicine exams, and even the cardiology exams. The United States Preventative Task Force recommended a number of years ago that certain patients have a one-time ultrasound to screen for a AAA. The patients who should have this screening done are men aged 65 to 75 who have any smoking history. Either they are a current smoker or they used to smoke and quit. So the way this will come up in a board question is a patient will be described as presenting for a regular annual visit. They'll have no complaints and appear to be relatively healthy, and they'll ask you what should be done next. And one of the answer choices will be an abdominal ultrasound. You'll probably wonder, why would anyone ever order that? Well, the answer is they would order it because it's recommended by these guidelines right here. And the idea is that men in this age group who have ever smoked have such a high risk of having a AAA that it is worth it to offer them a one-time ultrasound to see if they have an aneurysm that can be detected early and treated before it ruptures and leads to death. And that concludes our module on aortic disease.